increases of disease with age. So without further ado, Dr. George Kuchel.
What I didn't say is that my other qualification is I'm Canadian, so I can relate to the CAIRIBU. Very clever, very clever. The key is whenever you come developing something new, you need to come up with a nice, clever acronym. So congratulations. I've been interested at the interface of aging and urinary tract issues for many years. And going back to the days when you could fit everybody interested in that field probably in a small van or even a Beetle. But it's really, I just want to say how excited I am and honored to be here and to see so many of you here, but particularly people early stage folks. I think it shows the promise of the future of the field that I'm very excited about. So I'm going to cover a lot of territory today, which means that I can't really, we're not going to go really deeply into any particular topic. So I'd be happy to answer any questions afterwards. I'll be here until tomorrow. You can also email me. My email address is there. And I'm happy to also provide any references to things I'll be talking about today. So these are my disclosures. I have no relevant commercial disclosures. This is just to kind of illustrate what I was saying earlier. This is just taking a quick snapshot from PubMed, putting in the keywords aging and bladder, okay? It shows you the tremendous growth in publications. That big peak, by the way, is 2020. That's COVID related. I think every journal saw a big increase in submissions. But we're talking about 200 papers a year now, which is really phenomenal, covering the gamut of research. So one thing is, to highlight with you is that aging, so what I want to do, my talk is really divided into two parts. One is give you a bit of a kind of a geriatric lens as a geriatrician into what's the relevance of this interface between aging and the urinary tract function, because at the end of the day, it's all about the patient and kind of a patient-focused perspective. And I also want to, the second half of my talk is going to be focused on what we just heard about, this new word, geroscience, and what that means and where that is headed. And so one of the challenges in medicine in general, but particularly in care of older adults, providing evidence-based high-quality care for older adults, is this balance between giving too little consideration to complexity or too much. And we have a tendency in medicine and science to sometimes overcomplicate things for the public. We're often criticized of that, making things too complicated. But we also need to realize there's a real tendency here, as illustrated, to oversimplify things. And one of the big challenges historically in this area has been, to this day, in terms of how we take care of older adults with urinary tract issues, is that we tend to, as clinicians, we tend to opt for solutions that are simpler to implement, like prescribing a drug, as opposed to solutions that may be more effective. And I'll give you some examples of that, such as exercise training or lifestyle modifications, but are much harder to implement or get reimbursed, etc. So that's a real tension, particularly when caring for older adults. So I wanted to share some broader lessons from geriatrics that we've learned over the years. And for those of you who are familiar with this, my apologies. I don't want to kind of target this to those of you who may be new to the aging field. But again, even for those of you who've never worked with older adults or thought about aging, have older relatives who may have faced these issues. So first of all, I know some of you work in pediatrics, and children are not just merely smaller versions of adults. In the same way, we've learned that older adults are in fundamental ways different from the typical 30-year-old, let's say. Some diseases are associated with old age, such as Alzheimer's disease. I mean, fortunately, we almost very rarely see, except for very rare familial associations, we rarely see Alzheimer's disease in younger individuals. They're really diseases of aging. We have diseases that have the same name that have altered clinical presentations with old age. William Osler, many years ago, talked about pneumonia presenting in older adults very differently. It can often present just with nuance of confusion, delirium, or falls. Thyrotoxicosis in older adults often presents with just a fast heart rate or weight loss, as opposed to what you see in younger individuals. And I think we can make the case today that urinary incontinence falls in the same category. It can present exactly the same way in a healthy older adult as it does a younger individual. And it can also present completely differently. So same words, same billing code, but very different presentation and different management. Issue of frailty is huge. That's a talk in itself, and I'm not going to have a chance to talk about that. Decreased resilience, huge topic. Those of you who work at Duke can talk to your colleagues there about that. But one kind of overarching issue that I want to touch upon today that touches upon everything we're going to talk about is this issue, multifactorial complexity involving risk factors for what happens in old age. In fact, I tell our medical students, I tell them a little dirty secret. If you're asked a clinical question about an older patient and you don't know the answer, just say that it's multifactorial, okay? And if you say that, you'll be correct, okay? And the other thing that we've learned over the years, but only now beginning to pay real attention to it, is this issue of heterogeneity, this issue that when you've seen one older adult, you've seen one older adult. You know, you can't generalize. And that heterogeneity, this increased variability as we age between us, and also within us as individuals, the two different topics, involves risk factors. And we'll talk about that. Clinical presentations, you can have two people with pneumonia, two older adults, two people with incontinence presenting very differently. Multimorbidity, these issues, voiding issues in older adults almost never happen in the absence of other chronic diseases. So multimorbidity has to be part of it. Responsive treatment, everybody's familiar, those of you biostatisticians here, clinical trialists are familiar with the heterogeneity of treatment effects. It's true in clinical trials, it's true in everyday clinical practice involving older adults, and heterogeneity of clinical outcomes. So very, very complicated. So other than giving us a headache here, where does this leave us? So I'm going to kind of share with you some thoughts in terms of what we've learned over the years and where this is headed. But just to start by saying that there's a tendency to reach for the simple answer. You know, when you turn on the news, it's to reach for the one magical pill, okay? And just to share with you that this did not begin yesterday. It did not begin when the pharmaceutical industry, and it was the pharmaceutical industry, invented the term overactive bladder, okay? It wasn't us, it was the industry. It didn't begin then. Actually, if you look at the Merck manual, which turns out to be, I didn't know this until a few years ago, it's the longest continually published textbook of medicine in English. Began in 1899. This is actually the 1899 edition. So this is almost 2 centuries ago. And if you look in there, maybe too small to see, but there's a condition there that refers to bladder irritable, okay? So this is before ICS existed, etc. Irritable bladder. You don't need to read all the drugs recommended for it, some of which I would not recommend. I think arsenic is recommended for irritable bladder. But one of them is belladonna, which is basically, for everybody here, belladonna is from Italian, which is beautiful woman because of dilated pupils. And it's a drug, it's a plant-derived anticholinergic. And to this day, this is how the vast majority of our patients are treated, with anticholinergics for what's called overactive bladder. As you can see from this illustration here, anticholinergics have many important properties in the body, but drugs that are anticholinergics also have very important side effects, from dry mouth to constipation to urinary retention, potentially even worsening cognition. And I can also tell you, and this is a kind of cognitive dissonance right now that we have in care of older adults. On the one hand, we prescribe every day, thousands of people in this country are prescribed anticholinergic for overactive bladder, and at the same time, something called the Beers Index, which is published every few years by the American Geriatric Society, this is in JAGS, lists medications that are not recommended for use in older adults. And right there you have some of your favorites here. These are, half a dozen or so anticholinergics that are marketed, FDA approved, marketed, and prescribed for overactive bladder. I'm not saying they don't provide any benefits to patients. However, they need to be used highly cautiously, especially in older adults who have multiple chronic disease, who are frail. And if you do use them at slowest possible doses, use them only if other measures have failed. And I think that's the end of my lecture on that topic. But I think this has to be taken very, very seriously. The other issue that's come up is the issue of multimorbidity, frailty, and risk. And this is kind of highlighted here with this growing heterogeneity with aging. And that actually applies to almost everything you look at, whether it's basic biology of aging, whether it's clinical outcomes at the population level, everything in between. What this illustration shows is physical performance. So if you look at 100 older adults, you'll see some who run marathons and climb mountains and doing amazingly well, and others who are bedbound and everything in between. And so the challenge here in care of older adults, particularly in managing voiding issues, is that those at greatest need for treatment and the most to gain are also the ones that stand the most to lose in terms of side effects. So this is a real challenge. And this just illustrates the issue of polypharmacy, is that your typical older patient is on a multitude of different medications for different conditions. And those of you who take care of older adults, of course, know this already. Multimorbidity is just to illustrate the fact that by the time you get to over the age of 65, everybody has at least one chronic condition. And in fact, the majority have 3 or more. Okay, this is just the nature of aging, something to be taken into account. And this just to highlight just one quick example that we have a lot to learn here. You know, the tendency has been to think that this all happens randomly, that this is a random development of chronic diseases. This is actually a paper that came out from Korea in the journal Geroscience earlier this year that looked at a large community of over 1,000 community dwelling older adults, and basically did a principal component analysis to see how these different chronic conditions are linked. And I just want to highlight the fact that urinary incontinence is right there connected to other things. You don't have to get into deep details right now, but the point is that these chronic conditions are interconnected, they happen in clusters, and actually, as you'll hear, I'll share with you later during my talk, the underlying biology of aging is one of the ways they're interconnected, and that's why I'm so much interest in targeting that. But this is really something that we see in older adults. Now, there's a background here. I don't have enough time to share with you the rich history of geriatric medicine that my colleagues and I have been dealing with for many years that actually can inform many of these issues confronting us at this interface of aging and lower urinary tract issues. I just wanted to highlight kind of the overarching issues with a review paper that we published in 2007. This was published with several colleagues of mine that kind of defined the issue of geriatric syndromes and highlighted the fact that these are multifactorial conditions that typically only see in older adults and typically are, in addition to being highly multifactorial, they have this unique feature that they share risk factors. And this is going to be incredibly important when we talk about geroscience. The only reason that geroscience may work as a concept is because these biological hallmarks of aging interact with each other, and they represent shared risk factors between each other and also between different chronic conditions and diseases of aging. So this paper just kind of highlighted that and published in JAGS in 2007. It's hard to believe so many years ago already. And what this shows here is that, as illustrated here, is that you have these downstream outcomes, clinical outcomes on the far right. Your frailty is kind of intermittent stage. You have these geriatric syndromes, and these are conditions such as incontinence. And again, we are not talking about pure stress incontinence in a 75-year-old when she plays tennis, okay? We're talking about geriatric incontinence, okay? Same word, but different concept, okay? But also talking about things like falls, pressure ulcers, delirium, and functional decline. And you can see that the idea is to share these risk factors as illustrated here. And the idea is that you really need to move away from the linear model that's shown on the left of that figure, kind of the way we've traditionally taught both medicine and biological science is to think about A causes B and B causes C. So if you target A, you fix it. We need to think about these interacting risk factors as illustrated here in B, where anything we look at with aging involves multiple risk factors. And as shown in C, that some of these risk factors interact with each other in very important, very interesting ways that we're still beginning to discover. So I want to just give a shout out to some of my younger colleagues who are playing important roles in this. One who's not here, but many of you know, is Candace Parker-Autry, who's a urogynecologist at Wake Forest. And had the pleasure of working with her, knowing her for a number of years and working together. And this is just one of several papers that she's published and making an important role. What it basically shows was published in JAGS a couple of years ago, illustrating, these are patients, these are older women that she's seen in her practice for urinary incontinence. And the short of it is, and again, I'm happy to provide all the references to anybody who would like, just email me. What it basically shows is that it really reinforces their clinical practice. There are some ladies who basically have pure stress incontinence, who for all practical purposes have incontinence that's similar to what you see in their younger counterparts, okay? Now again, I'm not saying they're the same, but the incontinence has a lot of similar features. And then there are others who also have, and what she really focused on here is physical performance, okay? And these are ladies who have incontinence, but they're also more frail, and they also have slow walking speed and declines in physical performance. And she's making the case here, that urinary incontinence in these older ladies who have these multiple, or frail multiple, it's really a geriatric syndrome. And this is trying to develop an approach that will ultimately come up with better ways of diagnosing these women in the context of clinical care, better understanding what's going on, and develop better treatment for them. The other person you just met is Scott Bauer, who's really taken this approach more from the perspective of an epidemiologist, which is, while a general internist, Scott is an accomplished epidemiologist, one of the very few epidemiologists is approaching study of large populations from a geroscience perspective, has now started to look at it as just an illustration, looking at LUTs, focusing more on men, in terms of the role that physical performance plays in late life, avoiding issues and LUTs and incontinence, as well as body composition, and how that affects treatment. And as you'll see in a minute, we've actually known for a couple of decades that in many of these individuals, and I'll mention it right now, there's actually a seminal study published now almost 30 years ago by a colleague of ours, Joe Oslander. This was published in the UCLA VA system in JAGS, where he and his colleague Jack Schnell and the others showed that in older veterans living in the VA system who were incontinent, the combination of exercise training, the FIT trial, with some cognitive training was beneficial in a well-done RCT, was effective, was safe, there were no side effects, and it worked. The only downside, in the conclusion of the paper, they said, the downside is, and they recognize, it will never be implemented because nobody will pay for it. In fact, Joe shows slides. He is not part of the paper, but he shows beautiful slides. He has slides showing all the benefits, and then he has slides showing that the moment the study team left the facility, all the benefits gradually waned away. So this is a problem that has more to do with implementation science than anything else. So what does all this mean? And this actually, I'm very heartened to say that we're making an impact, and this actually is a picture from the 2023, the 7th International Consultation on Incontinence that I attended, and I know many of you did as well, that has kind of there was a chapter on management of incontinence, frail individuals, which I think was great progress, and it presented this approach that really encompasses all of the principles that I've discussed with you the last few moments, as well as here. So what are the take-home messages for this part of my talk? Well, multi-component interventions designed to address predisposing and precipitating risk factors work, and they work well. They work best for prevention. And I'm not going to have time to discuss it with you, but there's high-quality data from RCTs published in journals like the New England Journal of Medicine that have been done properly, that have now been actually moved into the implementation phase, that show that you can prevent delirium in hospitalized patients, you can prevent falls, not by prescribing a magical drug, but rather by coming up with a multi-component intervention that matches the risk factors for each individual. Because what that means is, the multifactorial complexity means that every individual, the risk for delirium is multifactorial, but it's different in every older adult. So it matches the risk factors with the intervention, or rather the intervention with the risk factors. So we know how to do this. I think there's a place for pleiotropic lifestyle interventions capable of targeting multiple different risk factors, and I think exercise and weight loss is a perfect example. These work, and many of you have been involved in studies that show they work for incontinence, and they work because they have highly pleiotropic effects on different risk factors. Now I'll show you some data why we think weight loss works, and actually probably is mediated by senescent cells to a significant extent. Now, there are also medications that have potentially beneficial off-target pleiotropic effects. We've known for years that statins have beneficial effects on cholesterol metabolism, but actually have all kinds of off-target effects on inflammation, etc. And now we're learning, everybody's excited about SGLT2s inhibitors and GLP-1 agonists for obesity, or diabetes and obesity. We're now learning that they have beneficial effects on things like congestive heart failure, mobility, physical performance. I'm not going to be able to show you, but there's high-quality data in New England Journal of Medicine that these drugs actually have among the best effects on physical performance in older adults with congestive heart failure, with preserved ejection fraction that you've ever seen, okay? We think, and there's increasing evidence, that may very well be mediated by a gerotherapeutic effect, okay? But that remains to be proven. Role for gerotherapeutics, and then finally a combination of the above, because, and I'm going to end my talk with this, because geroscience and gerotherapeutics cannot be only about prescribing medications. It has also to be about lifestyle choices, and ultimately also has to be about health disparities and issues like that, because all of these interact in influencing biological aging and therefore downstream chronic conditions. So it also highlights, I want to give a shout out here to my friend Phil Smith, who was on our faculty from 2007 to 2022 when he passed away from a sudden illness, for a couple of reasons. First of all, because it highlights his perspective to the system-based homeostatic perspective to lower urinary tract control with aging and incontinence that he developed. I've not had a chance to talk about his other contributions, such as the fact that he actually developed validated the first ever full-scale mouse urodynamic capacity, including flow, that had not been available before, and his work on the HCN channels, etc. But I also want to give a shout out to early stage colleagues here, because Phil joined us from actually, he was a primary care OBGYN in a small town in Ohio who thought he was interested in research. He went from knowing nothing about research to becoming one of our best funded faculty with an R01, 3 R21s, a decent award, etc., etc. So I think don't ever get intimidated by people who have lots of titles after their names or seem to know a lot more than you do. Okay, so there's hope for everybody. So I'm going to now shift gears to geroscience. So chronological aging is a risk factor for death from chronic diseases, and this is a slide that you may have already seen, but if not, this is taken from a chapter that we wrote, and this kind of illustrates how new this field is. So Hazard's textbook of geriatric medicine and gerontology, named after Bill Hazard, has been continuously published for about 40 years. This is the 8th edition published last year. This is the first edition that had a chapter on geroscience, okay? So this is a really new field, okay? So anyway, what this illustrates that is almost any chronic disease that you look at that typically occurs in older adults, whether it's heart disease, cancer, stroke, blah, 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 Alzheimer's disease, you name it, okay? Or incontinence is not there, but aging is by far, chronological age is by far the strongest risk factor. If you look at, so chronological age is how long you've been alive, okay? If you look at biological aging, which is a different question, related but different question, is how fast you aged over that time. Biologically, physiologically, that's even more powerful, okay? And it's really very, very strong. And just to illustrate what that means, just to give a couple of examples. So the risk of Alzheimer's disease increases 97-fold between ages 50 and 75. 97-fold, okay? If you look at everything we know about Alzheimer's disease, ApoE4, sex, being female, being a risk factor, hypertension, smoking, physical inactivity, and diabetes, that accounts for a 10-fold increase. So 9/10 is due to aging. And yet, we continually do Alzheimer's research in young mice, okay? Okay, it makes no sense, okay? And anyway, don't get me going there. It just illustrates the difference here. There are many reasons why that happens, okay? So this has to do with LUTs. This is taken from the ICS review that I talked about earlier. Again, for LUTs and related problems, again, aging is a very important risk factor. If we were, I don't have the picture here, but if we were to add obesity, both in men and women, metabolic syndrome, it would be even stronger. And I'll show some data from mice that we recently published. So, and then when you look at cardiovascular disease, and this is highly relevant to LUTs and incontinence, because we know there's lots and lots of evidence that vascular disease, particularly small vessel disease, particularly lower extremity vascular disease, plays a really important role as a risk factor. So if you could look at vascular disease, hypertension, smoking, cholesterol, diabetes, all important risk factors with increases somewhere between 40 to 60, 80%. If you look at age, completely erases it, okay? And yet we've completely ignored it. For decades and decades we've ignored it. So this idea of gerotherapeutics, I can't tell you how exciting this is, okay? I mean, in my own career, my own lifetime, my own career, the field of geriatric medicine has moved from a field that cares for older adults. It will always remain that, of course. It's focused on caring. And typically people who do care for clinicians who care for older adults would be living over here. People who study the biology of aging would live over here. And really not much of a need for them to talk to each other other than at the GSA or NIA. That has changed unbelievably. We're now working together, and in fact, this kind of segues into what I'm going to end up talking about, which is manpower issues and training next generation, which is incredibly important. So if you look at heterogeneity of physical function, the idea has been the hallmarks of aging. You heard a little bit about it yesterday. We used to think about the biology of aging in buckets. So people who studied senescence would be over here. Each hallmark, inflammation, you name it, would be studied by whatever you were interested in. Okay, I'm not going to go through all of it. Inflammation, telomere biology, proteostasis, autophagy. Everybody would kind of focus on what they're interested in. The fact is, they're all interconnected, deeply, deeply interconnected. And so the idea came up that these hallmarks of aging are on the path that these may very well be the drivers that drive this increase in comorbidity. So this is data published from Olmsted County, Minnesota, showing what I said earlier, that with aging, with chronological aging, there's a dramatic increase in multimorbidity. In this case, incidence of 3 conditions in men and women goes up exponentially, okay? So the whole idea of geroscience is that with gerotherapeutics, by targeting biological aging, we're going to be able to potentially push this back. And if we can do that, it'd be phenomenal. Just think about it for a minute. I'll get to it in a moment. We could potentially have an impact on all of these terrible chronic diseases of aging by pushing them later, pushing the onset later so that people can remain healthy and independent and functional for longer periods of time. Again, the focus is not to add more years to life, but if you can, that's of course good, but even more importantly, add more life to those years, okay? So if we could do that, that would be absolutely transformational. It would transform healthcare as we know it. The problem is that the devil's in the details. I'll be the first to admit, there's been a little bit of magical thinking in terms of how we're going to get there. And I think that there's work to be done. We're going to go through a little bit of that today, but there's certainly work to be done to understand a lot of very promising data, but still work to be done how we're actually going to get there. So this gets at the issue of those of us who take care of older patients, and for those of you who have family members who've aged and have to deal with health issues in later life, is what Felipe Sierra, used to be at NIA, now at Evolution, talks about the whack-a-mole approach to chronic disease prevention and management. This idea that what the healthcare system really does is we wait until the chronic disease occurs and then we treat it. And then, okay, it's better. But the next one comes. It's better, then the next one comes, etc. And often, the treatments that you did, like just pick a random example, the hormonal therapy that you institute, anti-hormonal therapy to treat prostate cancer in this gentleman here, causes him to develop increases the risk of osteoporosis and hip fracture next. And then that's treated, then he develops Alzheimer's disease, and et cetera, et cetera. So this, if we could do this, it would be absolutely transformational. And kind of how to get there, the way we're starting to think about is, how do you make sense of all this complexity? Because, you know, you could easily accuse me of magical thinking here, you know, what are you smoking, okay? So the way to get there, I think, and this is from our chapter in Hazard's textbook, is that the way of thinking about it. And I have to say, clinicians, particularly geriatricians, are skeptical. Because to be perfectly honest, you know, we've cured Alzheimer's disease hundreds of times now, almost weekly in mice. And we still don't have effective treatment for humans. So there's room to be skeptical. So if you look at the biological hallmarks of aging, as shown in those two columns on the left and in the middle, you have hallmarks on the left, which are more upstream. You have hallmarks on the right, which are a little bit more downstream. And then you have the onset of various syndromes, geriatric syndromes and diseases on the far right. And the idea is that if we're able to target one hallmark, this is the unitary theory of biological aging, that by targeting one hallmark, this has downstream effects on other hallmarks down the road, and then that can have effects, significant effects on multiple different chronic diseases and conditions, okay? And in fact, there's some early evidence that some drugs, perhaps senolytics, perhaps others, may work like this, okay? And that's a potential explanation. So biological aging, what has made us think that aging will be a modifiable risk factor? We know it's an important risk factor. So one has been a very important NIA investment, which is the ITP program, Interventions Testing Program, which is based at the Jackson Laboratory in Bar Harbor, University of Michigan, and University of Texas Health Sciences Center in San Antonio, which is the way to think about it. It's a coordinated multi-site clinical trial network for mice, okay, for aging in mice. And what they do, using highly rigorous protocols, they use outbred mice, so you avoid the problems that you have with inbred mice, which are numerous. They test different compounds using, and in fact, any of you can submit a compound that you think would be interesting. You can submit it to them. There's a committee to review it. If they publish it, you'll be a co-author. How's that? Okay. So to make a long story short, many years ago, colleagues of ours suggested rapamycin. So rapamycin that we use in high doses as an immunosuppressant for cardiac transplantation in particular, in low doses has important effects on mTORC1, which is an important, we heard about it yesterday, an important driver of biological aging. And a paper published in Nature in 2009 showed really powerful effects on longevity and then subsequently on lifespan and health span in genetically diverse mice, okay? That's now been reproduced many times. Just one example. The other one was actually published by a colleague of ours, a friend, Joan Manick, who's an infectious disease specialist, trained at the Mass General, then took a job at Novartis, and poor Joan, it's a standing joke between us. Every time I see her, I'm like 2 companies behind where she is. So I think she's like 6 companies behind Novartis, but she continues to do really high quality work, superb work, where what she's done is she's been laser focused on developing mTORC inhibitors that are more specific, because you don't want to inhibit TORC-C2, you want to inhibit mTORC-C1, and what she showed in 2 really important papers published in Science and Relational Medicine, that mTOR inhibition improves immune function in the elderly. These were older adults in New Zealand, Australia, who were community-dwelling older adults who were given the influenza vaccine, whose responses after being treated with this drug they were able to restore them to what they would have been when they were younger, and they subsequently able to show decreased rate of upper respiratory tract infections. So this is one of the reasons why our group, we do a lot of work in the vaccine space, and I'm not going to talk about it today at all. It's attractive for many reasons, but one of them is that you can actually do trials of gerotherapeutics over weeks or months as opposed to decades, okay? Because if you're going to have lifespan as an outcome, good luck. It's going to take you, in humans, it's going to take you decades and decades to finish it, whereas this you can do in a much shorter period of time. A lot of interest in metformin, which has been used for a long time as for type 2 diabetes. It also has impact on multiple different aspects of biological hallmarks of aging, especially on downstream inflammation. Just very quickly, New England Journal of Medicine paper showed comparison, very interesting design comparing metformin, ivermectin, fluvoxamine for COVID-19 prevention. Needless to say, the second and third had absolutely no effect. The first one actually had an effect, but the journal did not allow the authors to say that in the abstract because it was not a primary outcome. But the effect was there. Another paper published in Lancet Infectious Diseases, the authors from the University of Minnesota showed that it had an effect in a well-done study on long COVID. So again, this shows that the targeting biological hallmarks of aging has these important effects. This is the decreasing the rate of long COVID. Again, a complex condition, but I think the evidence is there. And just very quickly, SGLT2 inhibitors and GLP-1 RAs for non-diabetic diseases. This is taken from New England Journal of Medicine. The effects on physical performance in older adults with congestive heart failure with preserved ejection fraction is unbelievable. And it's way beyond its effects just in the heart, okay? So, and there's also growing evidence that these drugs may have effect on Alzheimer's disease because of off-target beneficial effects as a gerotherapeutic. Think about it for a minute. For decades, we've thought that the only way to develop a drug is to be as specific as possible, as clean as possible. Now we have an example here that off-target effects can actually be beneficial. And we'll talk about senolytics, which actually are dirty drugs, and that's good because they have these effects. I'll explain that in a minute. So I'm going to talk a little bit about cellular senescence and just give a shout out to two legendary people in the field who both passed away earlier this year. One was Len Hayflick, and I think everybody here heard about the Hayflick phenomenon when you study biology. This is basically when you take diploid cells from fibroblasts from any individual, they can only divide a certain number of times. And he and others had shown that if you take them from older adults, the number of times they can divide goes down. Judy Campisi then showed very elegantly that these cells secrete something called a SAF that I'll talk about in a minute. These secretory, senescence-related phenotype mixture of cytokines, chemokines, and enzymes that break down the extracellular matrix that appear to be how senescent cells have an effect on the surrounding milieu. So senescent cells are basically cells that can no longer divide. They lose the capacity to divide, but they can't die either. So they're stuck, and they continue secreting these molecules that are highly damaging. So the role of senescent cells, so senescence can be induced by DNA damage, telomere dysfunction, mitochondrial defects, metabolic stress, oncogenic insults, and aging. And as I said, they secrete the SAF, which is illustrated here, all these different molecules and many others. And this is just one way of diagnosing senescent cells, and there are many. I'll talk about this at the end, in terms of measuring DNA damage, in terms of measuring beta-gal staining, as well as P16 and P21, which are two of the traditional markers. And they accumulated with aging in many tissues, and there are two important models involving P16 that allow one to ablate P16 positive cells in mice with aging, generated by Judy Campisi and folks at Mayo, shown on the left, and then a P21 model, an inducible model that allows to manipulate P21 highly expressing senescent cells that Ming Zhu in our center had established that played an important role. And then our colleagues at Mayo, Jim Kirkland and Tamar Chkoni and others, have then come up with ways of doing siRNA studies in senescent cells together with system-based analysis that came up with these drugs that are already approved for other indications. In this case, we'll talk a little bit about this. Dasatinib, which is a tyrosine kinase inhibitor, already approved for use for chronic leukemia, combined with quercetin, which is a flavonoid, which basically, particularly when used together, have these effects on different tissues. And then this is work from Ming Zhu, who showed that these drugs in mice basically are able to alleviate frailty in aged mice. And there are a variety of different studies in humans, mostly phase 1, phase 2, showing the potential safety and potential benefits. Most of these are not controlled studies yet for in terms of diseases affecting these different tissues, as shown here, that are now moving into large trials, as illustrated here. And this is not only about D&Q, it's also about a variety of other senolytics such as fisetin, other different targets such as metformin, rapamycin, and others that have these effects. So not only these pillars of aging, hallmarks of aging interact with each other, but these drugs typically, they may predominantly target one hallmark, but they ultimately have effects on many other hallmarks. So I want to just segue quickly to some work that Iman Al-Nagar, who's an assistant professor in our center, just recently published in Aging Cell, where what she did was she took some young female B6 mice, she fed them a high-fat diet, which is actually a very simple way, if you want to accelerate aging, if you look at aging in your mice, the easiest way to speed it up is feed them a high-fat diet. She was able to show that they develop, in urodynamics, they develop a number of changes, particularly maximum decrease in maximum bladder pressure, that really resembles exactly what you see with natural aging, as shown in the figure below. She shows the same effect. So she took ear fibroblasts from mice, she irradiated them. That's the other way you can use senescence, irradiate them, and then did a senescent cell transplantation, and was able to replicate the same effects as shown here. And the issue of what constitutes a senescent cell is a topic in itself, very complex. I'll refer to a paper that we published in Senate recently. Here she showed that P16 and P21 were upregulated with aging in female B6 mice, but not in male B6 mice, not clear why. Also was able to show accumulation of S-beta gal, with aging that increased somewhat, but it was mostly maturational effect, mostly present in your epithelial cells, and you can see it very robustly even in very young mice. So this is an example where senescent cells, we think of them as being harmful, but senescent cells actually also play an very important role in development. And in this case, they can have beneficial effects. And as I'll show you in a minute, we actually think that senescence in urothelial cells is quite different from senescent cells in other cells. It's not DNA damage related. It's actually appears to be cyclin related to cyclin D1. And it may be, we think it's actually protective to keep these cells from going down the carcinogenic pathway. So there's different kinds of senescence as well. And so there's not advancing. Oh, there we go. And this just shows increase in P62 with RNA scope. But what she didn't see, she saw no difference with aging in telomere-associated foci or other measures of DNA damage. So this is senescence that's not related to DNA damage. Very, very different. And maybe because of that, she actually, these are very complex studies, because to administer D&Q to mice, you have to do gavage. And you can imagine these are lengthy treatments. You can give it intermittently, but the bottom line is, as you can see in the urodynamics on the left and the spot voiding on the right, basically there are important changes with aging, but D&Q had no effect. And one can speculate about different reasons, but it may be that the senescence we see in the bladder is quite different from what we see in other tissues, and it's protective in the ways that I mentioned, particularly since urothelial cells are this barrier of protection against this constant irritation from urine and toxic molecules there. So what Iman did next, I think, is phenomenal. She went from being a cell biologist, her PhD in cell biology, to becoming a clinical trialist. Not many people have done that. So she's now, thanks to our Pepper Center and also an AUA Scholar Award, she now is involved. She's very interested in the effects of inflammation, oxidative stress, mitochondrial dysfunction, deregulated sensing, all of which play a role in LUTS and metabolic syndrome. And she has a clinical trial called MitoLUTS that's testing MitoQ, which I'm going to go through this quickly for lack of time, which is actually nutricical. You can buy it without a prescription. That's being formulated. It's a mitochondrially targeted form of coenzyme Q, formulated to be actively taken up into mitochondria, and has all of these effects on multiple hallmarks of aging, as shown in red below. And again, as here, everything as illustrated here. And it's a proof of concept clinical trial, elucidate the effects of mitocule and LUTs in older women with metabolic syndrome, measure the effects on biomarkers, correlate biomarkers of age and blood severity. This is the protocol. I'm not going to go through it. Feel free to reach out to her. And incidentally, gerotherapeutics can have effects for other conditions as well. Another one of our pepper scholars, O Sung Kwan, is a kinesiologist, and he has a K01 award from NIA. He's actually looking at effects of mitocule on age-related declines in brachial artery flow-mediated vasodilation, and illustrated here, and with also examining physical performance and cognitive function that has just started to recruit. And I also want to give a shout out to a good friend, Lori Berger, who I think is well known to this group, who I've known for many years. She and her colleagues, Edwin Jackson and others, have done a lot of work on purine nucleosides in playing a role in age-related lower urinary tract dysfunction. And we started to collaborate because the deeper we look, these interventions, the paper that they published in JCI Insight, I'm not going to go into details for lack of time, we're now finding that these interventions have effects, downstream effects on multiple different hallmarks of aging that we've looked at so far. So I want to end up by talking about some networks which can be helpful, particularly for early stage folks. So our Translational Geroscience Network, which is an R33 award from the NIA. We have a website which is listed here. These are the institutions that are involved in. The good news is we just got refunded for another 5 years, so please visit, and happy to talk about it. This is from a paper we published in JAGS earlier this year, kind of illustrated what we do. We don't have the funds, we can't fund clinical trials, but for people who are planning to do a clinical trial of a gerotherapeutic, our mission is to help move that from bench into people, because that's incredibly difficult, okay? We can help with IRB issues, study design issues, biomarkers. We have a facility for geroscience analysis to measure biomarkers, etc. And this is catching on. There are half a dozen countries around the world that are planning to mimic this and replicate. And this is from Jack's paper, some of the trials that are currently, there are almost 90 trials, I think it's 86 now, that are currently part of this network. The other thing I want to mention very briefly is the NIH Common Fund Cellular Senescence, the CENET consortium that you heard about, which now, this is from our Nature Aging paper to show the tissues that it's mapping. This was funded about 3 years ago to develop high quality tissue maps of senescent cells in different healthy human tissues with aging, okay? Healthy, bladder is not among them. That's a long story. We thought about including it, and we would love to include it. And I think I'll get to that in a minute. These are the institutions that are involved and the techniques that we use. Again, I don't have time, it's in our marker paper from 2022. And the U54 that I lead, together with Vesna Geriatric, who actually is the chair of nephrology at Mayo, Nick Musey, endocrinologist who's moved from San Antonio to Cedars-Sinai, and Paul Robson, who runs our joint Yukon-Jackson Lab single-cell genomic facility, focuses on kidney, adipose, pancreas, and placenta. Happy to explain why placenta later. And I just want to very quickly focus on pancreas for one simple issue, because pancreas was by far the most challenging tissue to work with. Actually, our collaborating scientific officer is Dr. Kirsten Abraham from NIDDK, that I'm sure many of you who work there know. And it's the hardest tissue because there's no way you can get pancreatic tissue from a living, breathing human, okay? So we can only get this from people after who've succumbed to major car accidents and who are brain dead, basically, okay? So it's IRB exempt. On top of it, pancreas has all these, just chock full of enzymes. So it should be the worst tissue to study with, because there's a delay of like 12 hours or more between the tissue being, well, more than that, the tissue being harvested, the death, harvested, and sent to us. And yet, we are generating high quality maps and functional data, as shown here. This is work involving our colleague Jocelyn. The reason I'm saying that, if it can be done with the pancreas, it can surely be done with the bladder. So we've learned a lot there. This is a paper that I talked about. For those of you interested in markers, we've learned a lot. We're just beginning to submit our first paper with original data. I should also say that a key expectation of these common fund efforts to map cells is that the data is posted almost immediately on websites, okay? So this is all in the public domain. You can get access to it if you want. Just contact us. One thing we published is a review paper in Nature Review Cell Biology that came out earlier this year that has incredible amount of data in terms of best practices for studying senescent cells that I would refer you to. And I want to end up by talking about training next generation of translational geroscientists. There are currently 2 R25s in geroscience education in the country, and both are at UConn. The one at the top is to develop curricula for medical students, geriatric fellows, and PhD trainees, and also offers a certificate in geroscience research. The one at the bottom is for undergraduates. So this is incredibly important. And finally, I just want to say that all of this can only be done if you look at the whole person, okay? And again, I can't emphasize this enough. You cannot focus just on the bladder, okay? As important as it is. You need to look at the whole person, and it's really the focus of our Pepper Center, which is another NIA program project, Center of Excellence grant. There are 15 in the country, and I think many of you are institutions that have a Pepper Center, so you should certainly talk to them. And this is the focus of what we do. And I want to end up by talking about the fact that hallmarks of aging cannot be, you cannot ignore health lifestyle issues as shown here in terms of life's essential 8, or the geriatric 5 M's in terms of how to take care of older adults, or from the social determinants of health. These are all related. You need to look at all of them, and this has to do with how we approach clinical care. And we've just opened a Center for Geriatrics and Health and Aging that actually focuses on bringing all the providers to see the patient rather than shipping the patient around to see different providers, which we think is the way to move forward. So I'm going to end here by acknowledging my many colleagues, and happy to answer any questions now or certainly afterwards.